Yeah, thank you, Dr. Srinivas. It's always a pleasure, doing a case in your meeting, and I can understand why it's running late. I think it's a robust program, and you are actually doing a big job, managing this. So hats off to you. So
Thank you.
we are here with a live case from Medanta today, and I'm Dr. Rajneesh Kapoor, Dr. Himanshu, Dr. Ashish, Dr. Shashikant with me from the cath lab of Medanta, and all the technical staff, and then some image specialists are also here. So, we had two cases, and then we were actually contemplating what case to be selected for today's live case. Now, this case we did yesterday actually. Can we have the first, yesterday's angiogram? So, around 55-year-old gentleman, non-diabetic, non-smoker. Uh, Now, he had some acute coronary syndrome history about 10 days back. ECG showed inferior wall MI, and he underwent angiogram outside somewhere, some other hospital in Delhi, and which revealed a very critical TVD. But the culprit vessel was right coronary artery. So he got stented in the middle portion of the right coronary artery with the long stent outside about 10 days back. And then he landed up with this. Now this is RCA where there's a middle portion, there's a long stent, and that was as a primary done somewhere outside 10 days back. And he was also mentioned that there are other blockages. Either we think of bypass surgery for that or multiple stents. So with this, he came here, but the patient was very adamant that no surgery. He's not considering surgery. He's not even listening to surgery. So we also discussed the options of CABG, and if at all he's not ready, then it's for complex stenting. So this is RCA. We know there's a middle part taken care by PCI, primary PCI outside, and now there is a bifurcation lesion and sizable PD and PLB both. Next, next. No, this is okay. Next, next. No, can we show the angio? Okay, we can. So this is RCA. So we have done the RCA bifurcation stenting yesterday, and the circumflex also was a tight lesion. Next, next, next. Bacha, angio.
फर्स्ट जो यार उसी का ही first.
Yeah, okay. Now previous one, the circumflex. So this is circumflex, again a very tight lesion and a very big circumflex. So we fixed these two vessels yesterday. Now LAD had a very complex bifurcation. That's the reason we thought that let's keep it for the discussion here and do it perfectly. Next one. Now this is LAD bifurcation. Diagonal ostium is very critical, and LAD is also very, very critical. And there is a small aneurysm at the carina. Then the takeoff from the LAD, takeoff from this aneurysm of the LAD vessel is very tricky. And we knew that it's going to be tricky while wiring also. So this is the case, and as I mentioned, we did RCA and the circumflex yesterday, and we kept this bifurcation for today's live case. So this is the angiogram, and I think we'll absolutely like to listen any inputs. How do we do that? And then we plan to tell our strategy.
That's a great case. So thanks so much for showing it. Obviously the circumstances of the patient are, I think, what probably led you to do them on sequential days. Obviously, if you're going to use contrast, sometimes you'd be worried about doing so many procedures so quickly, especially with this complexity. But thoughts from the panel on how you would manage this? Obviously, the LAD is severe, the diagonal is severe. There's the aneurysm. He's already wired it, which is great. Sometimes these can be difficult to wire once you come out of the aneurysm. But people opting single stent, two stents, how would people do it?
Yeah, so the LAD looks disease right from the ostia. Look at the distal LAD size and the proximal, certainly the disease is from the ostia. And looking at the anatomy, the wiring of LAD is going to be very challenging, but it is already wired, isn't it? So that's a good break. And because the diagonal is also critical lesion and not a small vessel, So I think will have to be managed. Both the vessels need to be managed, and probably two-stent strategy would be required.
Anyone disagree with that? One thing that's interesting is oftentimes when the diagonal comes off at the aneurysm, the origin of the diagonal tends not to go down when you stent the LAD. So you
Absolutely.
could theoretically use, especially with drug-coated balloons, a strategy where you try to use that in the diagonal and just stent the LAD across the aneurysm. But curious to hear what you all have planned.
Okay, so I think as the discussion is going on, the wiring was very challenging. Almost it took us 25 minutes to wire LED. So I think that is one thing which is a point of discussion here also, that in such cases, how do we really wire? So next one. So
You
first
made it
wire.
look so quickly, so quick. So
No,
yeah,
it wasn't quick. It's
yeah,
looking as a quick one, but then it was challenging and took almost 20 minutes, 25
yeah.
minutes. So this is the first wire. Obviously, the direction wise, the diagonal is falling in line. So it went very easily into the diagonal. So we had a first wire BMW trying to go into the LED, not going. So this is a Fielder XT. Now look at this. This is the problem which we are facing.
Yep.
It was going into the aneurysm and taking a curl, and it was not getting directed towards origin of takeoff of the LED from the aneurysm. So then, obviously, since straight it was not going, we took innovative reverse loop. Next. So this is how it actually went. So this is a 20-minute effort, although yeah, in the end intervention looks easy, but there is a lot of effort behind the scenes also.
And
So this is
sometimes it feels
yeah.
almost random when you fall into that, but the use of the hydrophilic wire is really, really important because you have to basically defeat the friction of coming around the aneurysm. And if you take a regular wire, you will never do that and it'll prolapse down. So go ahead, keep going. This is
Absolutely.
great.
So this is how it started entering. It wasn't easy even after that. We were giving more pressure and it was kind of coming out. And slowly, gradually, with rotational movements, we were trying to advance it. Next. And then this is how. So I'm telling you, so we took a all reverse loop and then gradually advancing very slowly. And it went to some distance, but then got stuck. Next. So this is how it got stuck here. Now the loop in the aneurysm actually is making like a point on the wire, which is a weak spot. Next. So it got stuck here. I took a balloon support, 1.2 millimeter smallest balloon, and tried to place there. So once I went there, patient started having ischemic changes. We dilated the balloon there into the LED to continue with the flow. Next. Next.
And
Okay,
this is
so
where microcatheter can help a lot, obviously,
yeah.
but very nicely done and well done to show it.
So microcatheter initially I didn't take because LED is very tight. With the balloon also, without inflation, patient actually started having occlusion of LED and a lot of ECG changes. And then with the difficulty, we dilated the balloon, it slowly advanced across the aneurysm, and then we could get the wire down. So now after this stage, it looked relatively better. We dilated, we sequentially upgrade the balloon to 2 millimeter and then 2.5. We dilated the diagonal also to 2.5. Show
And
all the shots.
which wire is this in the LAD?
It is Fielder XT.
Yeah. And so one thing, the reason that personally I prefer using microcatheters in this situation is once you have the distal wire at that point, it can find small branches and you can get an exit perforation or something like that. So oftentimes you want to switch, but look, I think in this case, you have to fight with the patient with STs and everything else. So totally understand why you did it this way.
So we kept in mind that after this, if we find a difficulty in exchanging the wire, we'll use a Corsair, go down, and then exchange the wire on Corsair. But then after we dilated the whole thing with 2.5, we could exchange this with the All-Star wire. Next.
In fact, the distal end of wire is in a small branch. I think. Yeah.
It is. So obviously we had to give a bigger loop, bigger curve on the wire and on the tip also. So it was trying to enter into all branches. Next. So this is 2.5 millimeter balloon sequentially, and then we could exchange the wire with the all-star. Next. So this is a all-star wire coming down, and it was relatively fine, easy. So after we have done up till this stage, then we did a OCT to show it to you. So we have both the OCTs from the LED coming back and to the diagonal also. So I think what Dr. Ajay was mentioning here, we are also in that same situation, that that aneurysm actually will be a cushion for us in terms of bifurcation stenting. So we may not be requiring to touch the stents, because that's what our OCT image shows. So please run the OCT from LED first. Can we can we make a bigger screen for the OCT itself?
Yeah, we can actually see it pretty nicely, actually.
Okay. So this is that aneurysm area.
And this is from the LED, right?
This is from the LED, yes.
See the dissections.
Yeah, there are a lot of dissections. It was very, very critical lesion. And then we are coming back. The ostium of LED is relatively okay. There was some discussion on that. This is left main. Come back to the ostium.
So it looks like there's a landing zone there.
Yeah, there's a good landing zone 2 millimeter beyond the ostium. So we plan to start from there and then show the next OCT image also with the diagonal. So this is OCT from diagonal backwards. Again, this is that aneurysm area, and this is the LED. But now, as the pictorials of OCT get loaded, see here. So come further, come further. So this is the aneurysm part. Come distal, come distal, come distal. And this is the start of the diagonal lesion. So now it's a very critical lesion in the diagonal too. But then I think our strategy is that if we can just place our start of the stent just hanging into that aneurysm little, and then have a stent in the LED through and through, that should serve the purpose.
Yeah,
Any
I think,
comments?
yeah, no, I fully agree. There's no reason to make that bifurcation too complicated. And either way, you'd have malapposition within the aneurysm and the diag. So I think if you can do that, it'll make it a little bit simpler process. Any thoughts though to just trying to use a drug-coated balloon for that diagonal? And now at this point, that diagonal lesion looks relatively short, and that might make it even more simple.
I agree. So that is one school of thought, but then the way it is very, tight lesion and there are dissections already there.
Yep.
I think if we are also thinking of a very small 12 millimeter stent. The distal part of the diagonal disease we have dilated with the balloon, so maybe a balloon dilatation itself serves good there, and a small stent at the diagonal ostium, and then crossover stent from proximal LED to the LED area just beyond that septal branch. That is what we.
It makes a lot of sense. It's going to be hard. It may be harder to wire it after the LED is stented. You have the aneurysm, you have a dissection, and so the stent may be the simplest way to stabilize that and at least secure it.
Yeah.
So
can we have a first stent?
Yeah. So why don't you go ahead and so you're going to stent the diagonal first and then stent the LED? Is that right?
Yes, absolutely.
Perfect.
We'll keep it simultaneous, but yes, first diagonal stent. 2.5, 13.
So the other case is ready for us. So why don't you go ahead and work? Really nice demonstration, difficult case. Also think the patient had a lot more reserve because you treated the right and the circumflex first. So a lot of good education there. Why don't we move to the other room and then one comment as we move over.
What's the distal LED size here?
Yeah, distal LED size we have done. How much? Distal LED. Distal LED is 2.75 as per OCT.
And at ostium?
Ostium is 3.
And remember, one thing with imaging in these cases, also physiology, is when there's a lot of tortuosity, you can get wire straightening and your measurements may not be exactly what you think they are. So you also have to use some common sense when you do this and use stents that can expand to larger areas once they're straightened. All right, so why don't you go ahead and work? We're going to jump to the next live case 30.
So what we have done after we last got disconnected, we'll show it to you. Can you come back? So small change in our decision making, that we also stented the distal part of diagonal. It was recoiling after POBA. So we decided that no idea doing, taking care of the osteal lesion if there is no outflow. So this is this is where we left. Next. So this is 2.528 Zines at the distal diagonal lesion. Next. And then we were all set for the osteal diagonal. Next. This is 2.5 into 12 Zines again. We were very particular in keeping it just at the aneurysmal neck. I mean, just small, half a millimeter into the aneurysm. And this is simultaneously, we kept the stent in the LAD, but since this is not interfering with each other, there should not be an issue. We could have taken later also. So next. So this is diagonal osteal placement. Next. There was some residual. So we took a small balloon, 2.75, almost went up till 20 atmospheres. It's quite a fibrotic lesion there. Next. And this is how it looked. Diagonal taken care. We took out the wire at this point, the diagonal wire. Next. And then next. Okay. So then we placed this LED stent, and as we planned by our OCT image, just a millimeter ahead of the ostium. Next.
So just a minor point for people that are training is that if you're going to do this type of strategy, you want to make sure you do everything you need to do with the diagonal, taking care of any dissections or anything like that before you deploy the LED stent, because it's always going to be harder to come back in the diagonal once you stent the LED. And so if there's a problem, then you have to work even harder. So, I think this was good technique in that way. And the same thing can apply for crush stenting or any other two-stent bifurcation strategy.
Absolutely,
Yeah,
absolutely.
Do you think that proximal diagonal is not well expanded?
It looks like it could be a little bit more, but
yeah.
No, I think I'll show you more pictures. We have done the OCT after this, so I'm going to show you that. So it looks small pinching at that aneurysm point, but then we have done a OCT into the LED, and that shows that point where diagonal is taking off from that aneurysm. So after stenting the LED, there was some, almost occlusion of that septal branch, but this is coming back. Now we have post-dilated the LED stent with 3O balloon almost at 18 atmospheres. And then we have done a OCT pullback from the LED. Can you show us the OCT video? Yeah, from the start, yes. Okay, so this is the distal part of the stent in LED. Pretty well opposed. Stop here. Okay, so this is that aneurysm part.
Yep.
And see, now that pinching, I'll show you another aleocranial view also, but it looks okay. So now this aneurysm is connecting the LED and diagonal, and then diagonal is taking off from that aneurysm.
looks okay.
Yeah. So come back. There were a few points after this OCT video. We felt that we should post dilate it more. We have done that. We have done that also. Can you show us a aleocranial view? Yeah. Cranial more. Okay. Yeah. So this is how it looks. And then AP cranial once again.
How about the size of the LED stand, sir?
So we took 2.75 based on the distal LED size, but then we have post-dilated by 3O balloon up till 20 atmospheres. We have made more than... हाथ पीछे रखिए ऋषि, हाथ पीछे. हाँ, that's it. Yeah, this is how it looks. Now the septal has come back, and maybe a little bit more post-dilatation around the diagonal area, and we can have another OCT pullback to show it to you if we have time. This is 3O balloon. Okay.
Actually, in my opinion, because of the significant aneurysmal formation, I don't want to do the aggressive post-dilatation to that area, sir, because of to avoid some unnecessary complications. And it's my idea. Yeah.
20 down. No, that's a good point. because there is some weakness of the vessel wall there because of the aneurysm. Okay, 20 here. 20. Okay, down. Okay, let's have a last OCT image.
Yeah, I think that prox LED area probably can benefit from being more aggressively.
So again, this
dilated.
is 3 balloon at 20 atmospheres, is it?
Yes. And we are going in for the last OCT pullback for you. So idea is, I think the best part of interventional cardiology, every case is heterogeneous. And, this was quite a unique thing because aneurysm was there and wiring was very challenging. So I think we were anticipating a good discussion, which was obviously generated there by the panel. So this is the last OCT pullback I'm going in.
And once again, you're not going to dilate the struts into the diagonal, correct?
Since, there is a gap between the diagonal stent and the LED stent. So I don't think, and again, the same point which has been raised there, that's the aneurysmal part.
Yep.
So I think if it is fair, then let's keep it at this point only.
Yeah, even if you dilate, you will not be able to approximate the struts to the wall.
Absolutely.
Yeah,
We can't. That aneurysmal apposition can't be achieved.
It's interesting in this case and the last case.
Okay.
There are examples of a side branch stenting across that area with a gap and not dilating the struts. I definitely think there are people out there who would just open the cell with a 2O balloon just to be sure that you have access to the brain and to make sure there's good flow. But I don't know if there's any hard data that way, one way or the other.
So this is the last OCT after LED stent, and we'll run it for you. Yeah. So as compared to the previous one with more aggressive post-dilatations, it looks much better. The areas are much better, more than 6 all over. And this is that part of the aneurysm.
Yep. Which is pretty open.
Yeah. And please come back to the proximal point. Yeah. Come back. Yeah. So this is also pretty healthy.
That looks good.
Yeah. And run again, final.
And can you go to bifurcation view on the at the bifurcation itself? Just curious to see what it looks like.
Just make it 3-dimensional there at the bifurcation, this point.
Right there, right at that point.
Right there, yeah. From inside, yes.
And go to little distal, yep.
Okay.
So there you go.
Yeah, so this is the origin of the aneurysm and then diagonal taking off. There is a gap between the two stents, and that's how we planned actually. So no idea. Once we know that even if we have come back, we couldn't have opposed the diagonal stent, and it was giving us a small cushion then to avoid the jumbled up, crushing of the stents there. So any more discussion points, we are all...
Very, very nice demonstration. Thanks so much.
Yeah, thank you, Dr. Ajay, and thanks, Dr. Srinivas, for having us here.
Thank you.
It's really an honor for all of us from the team here from Medanta. Thank you very much.
But very critical bifurcation, very well done. Congratulations. All of the people sitting here in the hall have enjoyed your presentation, including with our chairpersons here, Dr. Ajay, Jivani and others. Thank you.
Thank you, Dr. Srinivas.